Okay, so now moving on to our presentation today, Harnessing Radioligand Therapy, Innovative Solutions for Advanced Prostate Cancer with Dr. Anthony Helou and Dr. Marc-André Morin. Currently Medical Director at Novartis Canada, Anthony Helou is a leader in the pharmaceutical industry. He was involved in the introduction of important vaccines with Sanofi and Pfizer, including Pfizer-BioNTech's COVID-19 vaccine. He has a Doctor of Pharmacology degree from the University of Florida and is committed to advancing healthcare and pharmaceutical innovation. Dr. Marc-André Morin is a doctor specializing in nuclear medicine, practicing at the Center Hospitalier de l'Universitaire de Montréal at the Center Hospitalier Universitaire de Quebec. He also holds a bachelor's degree in physiotherapy from McGill University and a doctorate in medicine from Laval University. At the same time, he is completing a master's degree in university teaching of health sciences at the University of Montreal. He is also known as the first doctor in Quebec to have infused radioligand treatment for prostate cancer. So without further ado, I will let our presenters carry on with this presentation.
Thank you so much, Mayor, for the nice introduction. Hello, everyone. So thank you very much for the invitation to join the Prostate Cancer Support Group webinar today. And I have the pleasure to have Dr. Morin, an expert in nuclear medicine, with us today. Dr. Morin, we're gonna share the presentation, and please don't hesitate, as Maya mentioned, to stop us if you have any question. And thanks for your interest in that topic. So we can go to the next one. So Dr. Morin and myself will be talking about an innovative precision medicine treatment for cancer. It's called radioligand therapy. Don't be scared. We're gonna demystify that. I will explain how it started, how it works, and how the future looks like. Dr. Morin will share with us his clinical experience using the product, and we invite you to ask any question, and please feel free to not hesitate to interrupt us if you want more clarification. Yeah, we can go to the next one. So the use of radiotherapy to treat cancer dates back to the beginning of the 20th century. So following the work done by Marie and Pierre Curie, do you know she was the first woman to win the Nobel Prize? So they used the treatment to treat cancer, and they did it with radioactive isotope. So it's really a particle that emit radiation, and that radiation can kill the cell. We're gonna explain that. So, however, the early techniques, as you can imagine, back in the 20s, it were not precise, not specific. That means it caused significant damage to healthy tissues. We can go to the next slide. So the technique has evolved, and one of the first application of radioligand therapy was the use of radioactive iodine. It's a kind of radioactive particle with iodine to treat thyroid cancer back in the 1940s. Why iodine? Because iodine naturally accumulates in the thyroid, and therefore it was expected if we use radioactive iodine, it can be taken up by the thyroid cells, allowing for targeted destruction of the thyroid tissue and the treatment of thyroid cancer while sparing the surrounding healthy cells. That was the principle. And the results were very promising, and this has taught us if we can deliver a small amount of radioactivity in a very targeted way to the cancer cell, we know that that radioactivity will kill the cancer cell and treat the cancer. So that actually marked the beginning of the development of the concept of radioligand therapy. We can go to the next slide to see how it works. So I have three clicks, Adam, but so as the name says, radioligand consists of two main components. So in yellow, on the right side of the screen is the radioactive isotope. This is the radioactive particle. This is the element that will kill the cancer. This is the lethal element. So that will emit the radiation and kill the cancer. And equally important, in blue is a small molecule. It's called ligand, or a carrier or a transporter. the main function, he has actually two main functions. One is really to carry the radioactive particle closer to the cancer cell, and secondly, to bind to the cancer cell. And I like to think of it like a very sophisticated GPS system. So where the ligand has the GPS coordinate of a type of cancer and transfer that radioactive isotope to the cancer, while where closer to the cancer is gonna the radiation will actually kill the cancer cell while sparing the healthy cells around the cancer cell. So we can go to the next one. Yeah, that's pretty much how it works. Next one, please, Adam. Yeah, so I have also 3 clicks here. So the radioligand is administered as an intravenous injection into the bloodstream, and then it concentrates at the tumor or target sites. Once at the tumor or target sites, the radioligand then binds to the surface of the cancer cell. We can go to the next one. Then the radioligand therapy is internalized into the cancer cell. We have also 3 clicks. Once in the cancer cell, it releases the radiation, and that radiation will break the heart of the cancer cell, so the DNA, and then will cause the cancer death. It does that in a very precise way, but it leaves the healthy cells largely intact. This precision that you see in his mode of action make it very effective while well tolerated, as well as is able to maintain, because we have less side effect compared to non-targeted treatment, it maintain the patient quality of life and also provide good pain control for the cancer. So you can see that we can build a platform from that actually technology, because if we have different ligand, that means who has different GPS coordinate for different type of cancer, then we can bring that radioisotope closer to the different type of tumor. So that's how we can develop new treatment from that. We can go to the next slides. So yeah, I use that analogy, and I think Dr. Morin will also use the same analogy, is we are at war against cancer. So the way I like to explain it, it's like a guided nuclear missiles, where you see we have the radioactive particle, and the ligand is responsible to carry that killing particle closer to the cancer site and then kill the cancer. Yeah, we can go to the next slides. I will not go too much in detail here. I will let Dr. Morin explain to you, but I just want to let you know that we can, the same as we can have different ligand transporter with different GPS coordinate for different type of tumor, we can also have different type of radioactive isotope. We can have one type that emits what we call killing radiation, which is alpha and beta radiation. So we use it for therapeutic to kill the cancer. But we can also switch that into what we call a diagnostic radioactive isotope. This is the type of radiation that travels far, like gamma radiation, and can be captured by imaging and the computer X-ray machine, and then we can visualize like a camera where is the cancer located. So you see, it has different purpose. So we can use it for treatment, and we can use it also to visualize where the cancer is located within the body. And also it allows us to see how effective is the treatment. This is quite neat, because you can see if you give some things, and you can visualize if that treatment actually works in the patient. So we can go to the next slide. So if you look at the image here, this is a PET scan of a patient with prostate cancer. In the red spot, these are the different metastases where the cancer is located. So you can see by using that product, we can locate exactly where is the cancer located and how spread is the cancer. And then we switch by using a killing radioactive isotope, and we can treat the cancer. So this is, if you look at the image at your right, this is, you can see there is less red spot, and you can see that after 2 cycles of treatment, the cancer has been removed from the patient. So radioligand allows us to see what we treat, pretty much. Now I'm gonna pass to Dr. Morin for the next section of the presentation. Yeah.
Thank you, Anthony. So we can switch. Yeah, thank you. So my name is Marc-André. Nice to meet you all. It's always a pleasure for me to talk about a new technology that is revolutionizing my specialty in medicine. I am a nuclear medicine physician. What is nuclear medicine? Don't worry if you don't know. Most of my doctor colleagues have absolutely no idea what I'm doing. So basically, it's a diagnostic specialty like radiology. We use radioactive substances to either treat or diagnose, make imaging of disease or condition or cancer. The major difference with radiology is that it is the patient that will emit the radiation following the injection, and the camera will collect all the radiation to make imaging. Whereas in radiology, it is the camera that will shoot X-rays towards the patient to make imaging. We can go to the next slide. Those are the toys we use in both departments. To your left, most people are used to that. It is the radiology equipment. So you have planar imaging with X-ray. You have 3D imaging with CT and MRI. And in nuclear medicine, we mostly use 2 types of machine, 2 types of technology. The first one is the SPECT CT. It's the first one on top right. It is used to make bone scan and to image function of multiple organs. There are 2 platforms just at the entry of the gantry. You can see the big donut. Right before that, you have 2 platforms that will rotate around the patient to collect the gamma rays in order to recreate 3D imaging of the system you want to see. In this example, bones. And on the bottom right, you can see the new kid on the block. It's the PET CT, which is a ring of detector that will collect all the gamma rays from the patient in order to make diagnosis and to image cancer. Next slide, please. Presentation by a nuclear medicine specialist won't be one without some notion of nuclear physics, but don't worry, I'll try to keep it simple. I want you to understand with what substance I'm playing in nuclear medicine. So basically, we use radioactive substances. Those are substances that are unstable, that has a lot of energy. And what do they want to do? It's go back to stability. How do they do that? They do decay. According to the decay, you might be able to make imaging or to treat certain cancer. So you can see on the left, there's a graph. The orange line is stability. That's what the radioactive substance wants to achieve. Everything on the right has more positive charge in its nucleus, so more protons compared to neutrons. It will decay in beta plus decay. That will enable us to do some PET CT, so PET imaging, only diagnostic, no treatment. And everything to the left of the curve has more neutron compared to proton, and it will decay with beta minus. This can be used for treatment and for therapy like lutetium-177. We can go to the next slide. I'll talk to you about theranostic. This is my subspecialty. I did my fellowship in that particular part of nuclear medicine. It's a neologism that gained popularity in the last few years. It combines the words diagnostic and therapy. We use ligands of specific targets that we can mark with different substances, radioactive substances, to image or to treat a certain condition in cancer. So it enabled the physician to treat what he sees and to see what he treats. It's a dream come true for any oncologist. You can make sure that the substance you are using is going to the right place in the right amount and to see if the patient responds or not. I love the analogy as well of the homing missile, since we are targeting only cancer cell and limit the radiation to healthy tissue and to healthy organs. We think theranostic is new, but as Anthony told you, it's not new at all. Actually, the first treatment of thyroid cancer patient was in the 30s, and the first imaging was in the 60s. So it's really not a new concept. It gained popularity in 2017 with the treatment of neuroendocrine tumor with octreotide that we can label to image and treat. And in the last few years with PSMA, RLT, radioligand therapy that we can use for prostate cancer. And that's the main subject of my presentation. We can go to the next slide, please. So as you can understand, theranostic is not one medication. It is a platform that we can use to treat various type of cancer, okay? This is the image of the year 2019 of our American Association of Nuclear Medicine. It used FAPI, which is a fibroblin activating protein inhibitor that is located at the surface of many cancer. And with this molecule, we were able to diagnose some of the most frequent cancer in the world: breast cancer, lung cancer, GI, colorectal cancer, with minimal uptake to the healthy organs. So we can see the big potential right there. Sometimes in the near future, theranostic could be used to treat all of these cancer. Can go to the next slide. Thank you. But today I will focus on my research on my subject of fellowship, the lutetium PSMA. So lutetium-177 PSMA. We'll go to the next slide. First half of the molecule, this is the Pluvicto molecule. The lutetium-177, remember, it's on the left of the radioactive stable curve. So it will release a pure beta negative radiation that is used for what? Therapy, for treating and burning the cancer cell. This molecule is quite interesting since it will decay with some gamma rays that will enable us to see the treatment while it's doing its effect. We can go to the next slide. The second part of the molecule is the PSMA, that stands for prostate-specific membrane antigen. You can find this transmembrane protein on the surface of normal prostate cells, but it is overexpressed in cancer cells about 100 to 1,000 times more. So it's a good ligand to make the diagnosis of prostate cancer, but as well for treatment. Once the PSMA lutetium will bind to the PSMA receptor at the surface of the cancer, it will undergo endocytosis. It will internalize all the molecule, and the radioactive product will be able to make its magic near the nucleus to kill the cancer cell. We can go to the next slide. And this is the combination of the two. Remember that one, there's a quiz at the end. I will ask you to draw the picture for me. So this is a Pluvicto molecule, a lutetium-177 PSMA molecule that will bind to the cancer cell. You can see there's a box on the left. It's called a chelator that will enable us to put some radioactive particle within it. If we want to image the cancer and not to treat, well, we can give gallium-68, and the box will prevent the radiation from altering the rest of the molecule. And if we want to treat, we change that gallium-68 molecule for a lutetium-177, and this will undergo beta minus radiation to treat cancer. We can go to the next slide. First of all, I want you to be familiar with the treatment algorithm in prostate cancer. As most of you know, when you're diagnosed with a prostate cancer, you will first try to get rid of it with surgery or with radiotherapy. Following that, we will follow some blood works to make sure the cancer doesn't come back. We will test for PSA within the blood, which is a tumor marker. If ever it comes back, you can give the patient hormonal therapy. There are first line, and if ever the PSA increases while you're under the first line hormonal therapy, your cancer will be castration resistance cancer. Then you can go with the second line. It's Xtandi, it is Zytiga. Those are called ERAT, second line hormonal therapy. And following to that, we switch to chemotherapy. You have two lines, Taxotere and then cabazitaxel. And after all of that, you can think of nuclear medicine and lutetium PSMA. We can switch to the next slide. What patient can we treat with lutetium PSMA? First, we have to have a non-operable prostate cancer that has spread to the lymph nodes or to the bone. That is called metastatic. We want the patient to have a progression under one line of hormonotherapy of second generation and one line of chemotherapy. And then we can discuss if the patient is eligible or not for the treatment, but every patient has to go within a PET PSMA scan to make sure the cancer cell overexpress the PSMA molecule. We can go to the next slide. Following that, I will look at the blood work of every patient to make sure they have a good hematologic reserve, so good red blood cell, white blood cell, and platelets. We want to make sure that the patient has good liver and renal function and that is relatively fit. More than 3 months of survival. And we want to make sure he's not incontinent because as you will see later on, most of the radioactivity will exit the body through the urines. So we can go to the next slide, please. So this is an example when we receive and when we order the parcels for the medication for Pluvicto. First of all of these steps are usually done by a nuclear medicine technologist. It is a specialty. It's not the same thing as a radiology technologist. We have one college degree that is offered in Montreal. We have one school right now. So the parcel will come like the first one you have on top right. It is sanctioned by the Canadian Commission of Nuclear Safety. You have multiple identification for the patient. You will look on the parcel. You also have the vial with the small labeling. It is shielded in order to prevent the radiation for the person surrounding. So it's heavy, it's in lead. You have also some ice pack because you need to keep the temperature underneath 30 degrees Celsius. The half-life of that molecule when it arrives is 5 days. So we have to inject the product within 5 days. And there's a small video, I don't know if it's working, but you will see on the right of your screen, we have a small fridge, which is in the lab that can contain hundreds of vials. So you can store a lot of it according to the type of cancer you want to treat. We have a lead fridge that enable us to keep all the material within the hospital lab. So we can go to the next slide, please. And there you go. That is our fridge. You can store a lot. You can see with the labeling. It's not really hard every hospital that has a nuclear medicine department have a lab like this, and you can store as much as you want for a lot of treatment. We can go to the next slide. So the treatment modalities, it's really simple, okay? It's an intravenous injection, very fast. It's about, you can inject in 1 minute if you want. As soon as a patient comes and go out of the hospital, it's 15 minutes max, okay? We give six cycle every 6 weeks. Those are called induction cycle. As you can see, this is my setup here at the Montreal University Center. You have 2 syringes, one with water, one with the radioactive product. We inject the product and then we rinse with water. We encourage the patient to drink a lot of water, more than 1.5 liters a day. Why? Because most of the radiation will come out of their body through the urines. And the patient has some homework and some radio protection measures to observe. It's a bit like COVID. You need to keep a 1 meter distance with people around you for at least 2 days. If you have pregnant women or young children in your entourage, you need to wait for at least 1 week before you can come closer than 1 meter. You have to need to sleep in a separate bed for at least 3 days or 7 days if there's young children in the environment, or 15 days if there are pregnant women in your environment. And then for sexual activities, you have to wear the condoms for 14 weeks if the partner is fertile. So that are the indication. You treat like when you treat, you have to respect the radio protection like that. And you can go to the next slide. The potential side effects really, really limited. When the patient compares to chemotherapy, it's day and night. If you look at the study therapy, which is a large study, multicentric study that was done in Australia, less than 30% of patients experience side effects from that medication compared to more than 50 for chemotherapy. When you look at the VISION study, that was a study that enabled Health Canada to approve the molecule Pluvicto. Only 12% of patients had to stop or to change a course of treatment because of significant side effects. I've done hundreds of patients, and the most common side effect is fatigue, at least around one patient out of two. So 50% of patients show fatigue, but it lasts for a few weeks. Okay, after 4 to 6 weeks, the energy will come back, and the following cycle, usually the energy increases. It is really the goal of our RLT treatment. There are some other side effects, but nothing that will change the course of action. You can feel some dryness in the mouth since there's a lot of uptake in the salivary gland, but no high-grade side effects were reported in the principal studies. You can see with the hematologic blood reserve, you can see some decreasing in red blood cells, but after all my patients, I never had to make a transfusion for red blood cells. The limiting factor might be the platelets, okay? Less than 10% might experience a large decrease in platelet. If ever it happens, you have to wait before you give the last dose or to decrease the dose. And sometimes, well, we have to stop the treatment. Unfortunately, it's the major side effects that was limiting the treatment. But as you can see, it's really minimal. The side effects compared to chemo is practically none. We can switch. And now the most interesting part, I will share my experience with some real life cases. We can go with the first one. So we're talking about Dr. S, that was a 74 years old man with a high-grade prostate cancer, Gleason 9. He was diagnosed in 2017. He had first-line hormonal therapy up to 2021. Then he became castration resistant with some bone metastasis. He had to receive a second line of hormonal therapy. I think it was Zytiga, that went well up to December 2021. Then he showed a progression in PSA. So he had to receive 5 cycles of chemotherapy up to April 2022. And he had a very special request for me. Actually, the patient energy level was very bad. He was going to bed more than 50% of the day. He was passing it within bed. He had trouble to tie his own shoe. He needed help for pretty much everything. His wife was doing everything for him. And his special request was that he was expecting a grandson in October, and he would like to see his birth. Okay, we were around early May, so I told him that it may be possible with that molecule, even though his fitness level was not that great. I said if the PET-CT shows overexpression of PSMA cell, we can undergo the treatment. So we did a PET PSMA CT. We can go to the next slide. And on the bottom right, you can see all the black spots. Those are cancer cells, okay, that overexpress PSMA receptor. So we can see that the disease had spread to the lymph nodes within the belly and in pretty much every single bones of the body. So I told the patient we could start the treatment. You can go to the next slide. And this is a very typical case, okay, of PSMA RLT. First of all, we did image the first cycle because remember, even though it's the lutetium PSMA is a beta negative emitter that is used for treatment, it also releases a small amount of gamma ray that we can put under our special cameras in nuclear medicine to see if the treatment goes to the right place. As you can see with cycle 1, all the radiation went where? In the lymph nodes that are cancerous and within all the bones that showed lesion. So it was similar to the PET-CT, so that was a good response. At the baseline level, the PSA was 572. You can see after cycle 3, we almost reduced by 50% the PSA level, and you can see some shrinking of the tumor within the belly and within the lymph nodes and within the bone. At this time, the wife of my patient went home, and his husband was gone. She was expecting the worst to find finally his husband in the garage working on the lawnmower. Yes, after 3 cycles only, his energy level was so good that he was able to do the lawn, to mow the lawn again. So it was a great response clinically. And then you can see after 5 cycles, the disease shrunk by the 3/4. And the PSA level lowered to 105. So that was a typical response of PSMA RLT. We can go to the next slide. And the question, well, you can see the decrease inside. The bottom picture is the first cycle, and the top picture is the fifth cycle. Remember, treatment with RLT, as I told all my patients, we do not want necessarily get rid of the cancer. Most of the time we can't. When the cancer has spread everywhere in the body, we cannot get rid of it. The goal is to chronicize the cancer, okay? We want to keep it asleep as long as possible. So stable disease is a good response. Partial response is a good response. And sometimes we want complete response, but it's quite rare. So that was a partial response. We had 3/4 decrease in all cancer cell. That was very good. You can switch slide. And the question you're all waiting for, the patient did see the birth of his grandson, and moreover, he celebrated his first birthday with him. So he had a lot of survival increase with our treatment. I was really, really happy with that. Unfortunately, last November, he passed away, but not according to his cancer, but for heart failure for another condition. So this is really a typical reaction to the RLT PSMA treatment. You can see, we can go with another example. Case number 2, 76 years old man that received 2 lines of hormonal therapy, 1 line of chemotherapy, that was fit, that had a great expression of PSMA on the PET-CT, was eligible for treatment. So we did the treatment. You can switch. To the left, you have the baseline PET-CT. So you can see all the lesions that are within the lymph nodes, the bones, and there was some lesion within the belly implant called carcinomatosis. So that was the first picture. The middle picture is post-cycle 1. So you can see that all the dose went to the right place. So you can see what you treat. And then we did some imaging after cycle 3. And what you see is only activity within the bowel, some in the liver, the small black spot you see in the head, or lacrimal and salivary gland. So that's all physiologic, but no more cancer. That is a really rare response, but it's a complete response. Okay, this is not the norm, but it can happen. 9% of patients did a complete response in the vision study, and the therapy Australian study, 7% of patients did it. That was spectacular. We can switch slide. As you can see, most people have partial response, but complete response is possible, and stable response is good as well. And we can go to the next slide. That was a quite spectacular response, but I wanted you to see the spectacular response and the typical response, but it's really promising with the lutetium PSMA. Here you have some evidence. The first trial was done on 30 patients. It was done in Australia. It's the Hoffman team that did it. We give lutetium PSMA to patients that was end-of-line treatment, so they received 2 lines of hormonal therapy and 2 lines of chemotherapy. The PSA response was great. More than 50% of patients did experience a lowering of 50% of their PSA. Bone improvement, bone pain relieved by 90%. So when you think of lutetium PSMA, you have to think quality of life, okay? Low side effects and lots of quality of life. Overall health improvement was more than 37%. We can switch to the next slide. One of the major study was therapy study. I told you about it in my last slide. It's a multicentric Australian study, also by the team of Dr. Hoffman in Melbourne. So it was challenging the second line of chemotherapy. So we were RLT, lutetium PSMA versus cabazitaxel. And despite the fact that this study did not succeed to achieve overall survival, it did improve the progression-free survival. And according to me, that's very important, because for quality of life, if you can stop the disease from growing, it's really important for the symptoms and everything. So if you can see, the PFS was increased of 19% at the 12 months compared to 3% for the cabazitaxel, and way less side effect, as I told you before. That was therapy. And then we can see the last study on the next slide. It's the vision trial. That's the multi-centric and multi-international study. It was conducted that led to the approval of Pluvicto by Health Canada. It shows increased survival and increased progression-free survival. And you can see a lot of decrease in pain, in quality of life, in the stability of the disease. You can see that 42% of patients had a partial response compared to 3% on the standard treatment. So it's this treatment, we also treat all the patient at the end of treatment, but even when we get the most sick patient, we did add some improvement in all the following point and all the following measure. So that what it's done right now, that's the literature that did the approval of the molecule, but we can see on my next slide that a lot of study are ongoing right now because the goal of those study is to see how much survival we can get if we give the treatment sooner. Right now, the treatment is limited for people who had 2 lines of hormonal therapy and at least 1 line of chemotherapy. But there is some trials that are challenging the first line of chemotherapy to see if it's better to use lutetium right away. And this is called the PR21 trial. We did some patient that went well in the last few years. We're still waiting for the results. It should come out in the next following years. There's a SPLASH trial that is comparing second line hormonal therapy versus RLT, lutetium, PSMA to see if we can give it to patients that are starting to become castration resistant. And then there are some trials like PSMA addition that are trying this molecule on patients that are still hormonal sensible, that still respond to hormonal therapy. And some people in Australia try to give that molecule prior to surgery to see if it decreases the rate of metastasis and the rate of coming back, of reoccurrence of the cancer. So well, with all those studies, we're trying to see where we can fit our molecule in the algorithm to have the most improvement. And the future looks very bright, even though like we had good response with the most sick patient, but we want to see how far we can bring that molecule. So I think that was my last slide. I will let you with Anthony that will continue the presentation. I think we can. So now we have one last slide. The challenges. So first of all, prostate cancer, okay? It's the #1 enemy for men, okay? It is the most frequent cancer. It's 1 man out of 7 that will receive the diagnostic during his life. It's about 25% per year in Canada, new diagnostic per year. And once this type of cancer is metastatic, so when it has spread to lymph nodes or other organs, the 5-year survival is under 30%. So we need that molecule. We need something to improve survival. And this is a potential large pool of patients, so a lot of treatment. And all those patients need to receive a PET CT. In Quebec, we are really lucky because we have more than 10 PET CT around the province. Even here at the CHUM, we have 2 of them, but in some province, like in BC, we have maybe 2 for the entire province. So it might be a challenge for us because we need the PET CT before we treat the patient. And it's such a it's such a big pool of patients that it might be a little bit overwhelming for the nuclear medicine department. You can see that my specialty used to be a diagnostic specialty. We used to read imaging. We used to make diagnostic, but not to treat patient. And right now it's shifting. Now we have patient. We need to monitor patient, to follow them, to treat them. And that will be a good challenge for our specialty. And yes, that's pretty much it for my part of the presentation. I'll stay around if you have any question, but now I'll switch to Anthony. Thank you.
Thank you, Dr. Morin. So just to finish by saying we have 2 products that has been approved on the market. We have Lutathera approved by Health Canada in 2019 to treat neuroendocrine tumor. And we have Pluvicto for prostate cancer in 2022. Lutathera has been publicly funded by most provinces in Canada. Pluvicto is not. So it's not publicly funded for the eligible population at this time. Quebec, however, because of the need among certain patients with metastatic prostate cancer, some clinicians have obtained access to Pluvicto, recognizing that this treatment not only prolongs life of the patient, but also is well tolerated and allow for a better quality of life at this late stage of the disease. And that is part of the hospital, not the government. So the hospital was able to secure a budget. So right now we have an inequity for access for this treatment, and we hope to address that ASAP. Also, we are investing heavily on radioligand. We believe it's going to be the next big thing for cancer treatment. We're investigating it for brain cancer, lung, kidney, pancreas, and breast. There are studies ongoing, and there are more than 20 clinical trials on the way, with more than 10 pharmaceutical companies are also developing radioligand. So we can go to the last slide. So as you can see, and we can go to another click for the last slide. So as you see with radioligand, we believe that we are just scratching the surface, as Dr. Morin said. Our goal is really to defeat cancer. This is why we are here, and this is what we're passionate about. And we believe it's going to be one of the solutions. And with in addition to the other treatment modality that exists, and together we think we're going to become the new standard of care to treat cancer. So thank you so much for your attention, and we're happy to take questions. So thank you so much.